everyone, today my group and we are going to be discussing immunity in the pediatric population. But before we go ahead and start, I'm going to introduce each and one of us. So my name is Erica Zambrano, and as part of the group we also have Victoria Atencio, Melissa Galindo, Alexis Ramsey, and Lila Summers. Presentation outline. So first we will be going over the concept overview, which will consist of a short definition for immunity, pediatric considerations, and also interrelated concepts. Then we will be going over 5 different exemplars, the first one being HIV and AIDS, the second one being hypersensitivity, the third one being lupus, the fourth one being transplant rejection, and the fifth one being immune response. Then we have 3 discussion questions for you guys, and then we also have a quick thank you message as well as a works cited. So let's get started. Concept overview. So immunity can be defined as the physiological process that provides protection and defense in response to invasion and foreign substances. Pediatric considerations include vulnerability. So newborns are very susceptible to infections and diseases due to the lack of mature immune responses. Vaccines and immunizations. So it is very important to give pediatric patients their vaccines during the recommended periods or windows so that they are able to develop an immune response to possible infections and diseases that they may come across. Pediatric patient education. So it is very important to consider their developmental stage and what educational and communicative methods to use in order to provide them with the information that they can easily understand. Parent education. So if the pediatric patient is not old enough to provide consent or decide for themselves, then it is also really important to consider their parents when developing a plan of care as well as educating them so that they know how they can support their child. Interrelated concepts include inflammation and infection. So a patient with an immune disease will frequently present with inflammation and infections due to an either unresponsive immune system or a lack of antibodies or an insignificant number of lymphocytes to help them fight off these invaders. Of course, inflammation is a response to a possible infection. We also have tissue integrity. A defect in tissue integrity will cause the body to invoke an immune response, which will then lead to inflammation as well as infection if not treated, especially if the immune response is not efficient. We also have stress. This can be a pathologic influence that can lead to immune dysfunction and can also cause an alteration in glucose regulation. Nutrition, an inadequate diet can lead to immune dysfunctions due to a lack of necessary nutrients needed to provide the body with protection. It is also very important to determine allergies to foods, as it can cause not only very harmful effects, but it can also be fatal if it's not treated. And this would also be considered an exaggerated immune response. And then lastly, we have fatigue. So this is a huge stressor to the body, which can cause an individual to become immunocompromised or cause an exaggerated pre-existing immune response. HIV and AIDS. So HIV is an acquired immunodeficiency disorder that causes a wide spectrum of manifestations. AIDS is the most advanced manifestation of this infection. Risk factors for HIV and AIDS. So HIV can only be transmitted through contact with infected blood, semen, vaginal secretions, or breast milk. Risk factors for infants include vertical transmission or delivery and breastfeeding when the mother is already infected. And according to evidence-based practice, if the mother is not treated and there's no prevention provided, there's actually a 15 to 25% chance that the infant becomes infected. Likewise, without appropriate prevention, if the child is being breastfed, there is a 5 to 20% chance that the infant becomes infected. As for older pediatric patients, teenagers and adolescents are more likely to become infected through sexual activity due to the lack of use of condoms, and drug use, in which they may become in contact with infected blood products when using needles. And these are actually two things that we are going to be discussing in more depth later in this presentation. Assessment in patients with HIV and AIDS. So during assessment, it is important to consider the patient's history. If they're infected, it is important to understand how the infection was contracted in order to determine appropriate nursing interventions and teachings. Additionally, during assessment, it is important to determine whether they have a history of concurrent infections, whether they're yeast, bacterial, viral, or other fungal infections. Exam findings can be challenging to determine in neonates because they're usually asymptomatic, which is why it's important to consider diagnostic tests and blood work. In older pediatric patients, there will be an abnormal size of lymph nodes, an enlarged liver, and swelling of the spleen, oral yeast infection, weight loss, chronic diarrhea, and pneumonia. For diagnostic findings, they consist of both maternal blood test and the pediatric patient's blood test. So, maternal blood tests are needed in order to determine if the mother is infected and to provide intervention so that the neonate does not contract the infection upon delivery. If the pediatric patient is infected, their blood work is needed to determine the CD4 count, HIV DNA polymerase chain reaction, as well as viral load, all of which help determine the progression and stage of the disease. Clinical management for the pediatric patient with HIV and AIDS. So, nursing interventions are going to consist of encouraging small, frequent meals to promote nutritional and fluid intake, assess the child every 2 to 4 hours for fever, enforce good hand hygiene, and screen visitors for colds or any other recent exposure to infections, and compare any noted changes in appearance or presence of infections with every single visit. As for collaborative interventions, it is important to monitor HIV progression and immune function, initiate and monitor antiretroviral therapy, otherwise known as ART, prevent the development of opportunistic diseases and treat them if they're present, as well as managing symptoms and decrease complication. For treatment, the goal is going to be to prevent further transmission of HIV, slow down progression of the disease, and increase CD4 cell count. So, antiretroviral therapy is used to inhibit viral replication, making it difficult for the virus to recover. Primary, secondary, and tertiary prevention in the patients with HIV and AIDS. So, primary prevention consists of education and neonate prevention. Vaccines and immunizations are very important in building an individual's immune system. As we know, a person who contracts HIV and or AIDS is very susceptible to contracting many other diseases and infections. So it's very important to educate patients about the importance of receiving their immunizations, whether they have HIV, AIDS, or not. An important side note to consider is that HIV and AIDS are not what causes fatality, but actually the secondary infections contracted as a result of a weakened immune system. Additionally, it is very important to consider what immunizations have to be administered with precaution, as some live vaccines can be harmful to an individual with an autoimmune disease. Discuss ways to prevent HIV infection, such as practicing safe sex. So, this is highly important to discuss with pediatric patients who are at the ages between 12 and 18. Kids around the age of 12 or maybe even younger sometimes, they may possibly begin to have sex at classes in school and they become curious. And although they may not start having sex at such a young age, it is important to teach them about the importance of protection, both birth control and condoms. Of course, birth control can reduce the chances of pregnancies, but not STDs. So it is very important to discuss the use of condoms. This obviously applies to teenagers who are older as well. We can never assume that because they may be older or in high school, they are educated or informed on the topic. So, educate them no matter what. Avoiding drugs especially those in which needles are used, is highly important. Many times it is common for drug users to reuse and share needles without realizing that some STDs, one being HIV and AIDS, can be transmitted. With neonate protection, it is necessary to bathe the infant as soon as possible right after delivery and wash the eyes and face before administering prophylactic eye drops or ointment. These are crucial preventive methods to reduce those chances of neonate contraction of HIV and even other diseases and infections. Secondary prevention consists of screenings. So, HIV screening consists of blood work showing evidence of CD4 cell count and viral load. A low CD4 cell count may indicate the progression of the disease as well as an increase in viral load. So, it is important to have blood work done frequently to determine whether the disease is progressing and determine the issue, such as noncompliance to medications, and decrease the chances of HIV progressing into AIDS. As discussed before, individuals with HIV and AIDS are more susceptible to other infections due to an ineffective immune response. For such reason, along with regular assessments, it is important to perform blood work and culture specimens to rule out or detect infections. As for tertiary prevention, that consists of treatment and collaborative interventions when the disease is already contracted. ART, or antiretroviral therapy, is efficient in preventing HIV from binding to cells, inhibiting transcription of HIV DNA, and preventing HIV proteins from forming into the appropriate length needed to allow variants to assemble and put out from the cell membrane. It is also possible for more than one drug to be combined into one tablet to create an efficient effect needed to treat HIV. Growth and development in HIV and AIDS pediatric patients. So, important considerations to make when caring for pediatric patients with HIV and AIDS are number one, the progression from HIV to AIDS. So, because children may not have a fully developed immune system or in general are not fully developed, they're more likely than older individuals to progress from HIV to AIDS. Number two, neonates, for obvious reasons, cannot speak for themselves, and many times they're asymptomatic. Screening them is highly important, even if they seem healthy, and especially if the mother is already infected with HIV or AIDS. Number three, etiology of HIV and AIDS in children differ from adolescents and adults. So, while children are most likely to contract the disease from vertical transmission during delivery or breastfeeding, adolescents and adults are more likely to contract it from sexual activity and the use of drugs, as discussed previously. HIV and AIDS cause physical and developmental failure to thrive in children, as the disease can result in muscle wasting, weight loss, organ dysfunction, and malnutrition. Lastly, for HIV and AIDS, we will be discussing patient and family education. So, because pediatric patient care is more than likely dependent on family decisions and wishes, it is important to provide family centered care. It's important to determine the family's culture, beliefs, values, as well as determining family roles and who will most likely be the caregiver for the pediatric patient. Um, we have to remember to not assume that the mother will be the primary caregiver because, in some instances, they may not want to become responsible, or it may be determined that someone else in the family is more fit to care for the child. Depending on the pediatric patient's age, the teaching is influenced by their communication skills and understanding. While younger children may require the use of pictures, toys, or even allowing them to play with the equipment used, such as the stethoscope. An older pediatric patient can fully understand and communicate efficiently, although it may be important to avoid sophisticated medical terms. Patient teaching includes how the disease is contracted, how to stop the spread, and its signs and symptoms, progression, and treatment. If acquired through vertical transmission, explain both child and parent disease process, importance of following through with medical treatment and noting potential problems that necessitate calling the healthcare provider.
Hi everyone, my name is Lila and I'm presenting the exemplar of hypersensitivity. First, I'll go over the definition and the types of hypersensitivity reactions. Then I'll discuss the risk factors, assessment techniques, and clinical management for an exaggerated immune response. For the growth and development sections, I picked out 2 exemplars of hypersensitivity that are common in the pediatric population to review. Hypersensitivity reactions. A hypersensitivity reaction occurs when the immune system produces an overreactive response against a foreign or self-antigen. There are 4 types of hypersensitivity reactions, which are discussed in more detail on the next slide. Symptoms can range from mild, such as those seen with allergic rhinitis, to moderate and severe, such as during an asthma exacerbation or anaphylaxis. The exaggerated immune response seen in certain autoimmune diseases is also a type of hypersensitivity reaction in which the immune system produces antibodies against self-antigens. Types of hypersensitivity reactions. Hypersensitivity reactions can be classified into 4 types based on the immunologic mediators, the time until reaction, and the source of the antigen. In type 1 IgE-mediated reactions, exposure to an allergen causes increased levels of IgE, which leads to an allergic reaction. Examples include allergic rhinitis, also called hay fever, asthma, and anaphylaxis. In type 2 cytotoxic reactions, IgG or IgM antibodies bind directly to an antigen on a cell surface, which activates the complement system and leads to tissue destruction by lysis or phagocytosis. An example of this reaction is a hemolytic transfusion reaction. In type 3 immune complex mediated reactions, antigens combine with IgG and IgM antibodies to form complexes in the body's tissue, resulting in the activation of the complement system, inflammatory response, and tissue destruction. Examples of this type of reaction are systemic lupus erythematosus and rheumatoid arthritis. In type 4 delayed reactions, T cells that are sensitized to an allergen attack antigen or release cytokines. Enzymes released at the site cause tissue destruction. Examples of a delayed hypersensitivity reaction include contact dermatitis and transplant rejections. Risk factors for hypersensitivity. Risk factors for an exaggerated immune response include age. Many allergies are chronic, but some increase or decrease in severity over time. Gender, race, and ethnicity. Women have higher rates of autoimmune diseases, and African American, Hispanic, Asian, and Native populations are more likely to develop systemic lupus erythematosus. Hypersensitivity reactions are sometimes associated with a genetic predisposition. A family or personal history of hypersensitivity reactions increases the risk of developing one. Finally, exposure to a known allergen or a trigger increases a person's risk of developing a hypersensitivity reaction. Clinical manifestations of hypersensitivity. Signs and symptoms of a hypersensitivity reaction range in severity from mild to severe and vary based on the type of reaction. Manifestations may be localized or systemic. If the patient has been exposed to an allergen in the form of medication, food, medical treatment, or insect sting, monitor them for signs of anaphylactic shock, including angioedema, erythema, urticaria, dyspnea, adventitious breath sounds, tachycardia, cardiac and respiratory arrest. Early recognition of anaphylaxis helps increase the efficacy of treatment and reduces negative health outcomes. In type 3 immune complex and type 4 delayed reactions, signs and symptoms of hypersensitivity may take hours or days to appear. Diagnostic tests for hypersensitivity. There are several laboratory tests that can be performed to determine if a person is experiencing a hypersensitivity reaction. A complete blood count with differential can determine if there are alterations in immune function. A positive antinuclear antibody test may indicate an autoimmune disorder. C-reactive protein and erythrocyte sedimentation rate tests can detect inflammation. For allergies, a skin test can help identify the allergen, and an IgE blood test is used to measure the allergic response to an antigen. The rheumatoid factor test can detect the presence of autoantibodies and help confirm an RA diagnosis. A complement test is used to determine deficiencies in the complement system that are associated with autoimmune dysfunction. Organ function tests, such as a thyroid screening panel or hepatic function tests, are performed to determine disease progression and evaluate the effectiveness of treatment methods. Clinical management of hypersensitivity. For emergency management of a hypersensitivity reaction, the priority is to maintain respiratory and circulatory status. Patients experiencing hypersensitivity may need to be placed on oxygen, ventilated, or intubated. Blood pressure can be maintained or restored using normal saline boluses, plasma volume expanders, and vasopressors. Vital signs including heart rate, respiratory rate, temperature, blood pressure, and oxygen saturation should be monitored per facility policy. Pharmacological management of hypersensitivity reaction includes adrenergic agonists, corticosteroids, bronchodilators, antihistamines, and non-steroidal anti-inflammatory drugs, depending on the type and severity of the reaction. Primary prevention of hypersensitivity. Primary prevention of hypersensitivity reactions focuses on allergen and trigger avoidance, eliminating foods and medications that cause an allergic response, and minimizing exposure to environmental triggers such as dust, pets, or pollen is recommended. For infants at high risk of developing a food-related hypersensitivity reaction, there is evidence to suggest that introducing peanuts between the ages of 4 to 11 months and eggs between the ages of 4 to 6 months may help to reduce the risk of allergy development. Secondary prevention of hypersensitivity, screenings. While there are no routine screenings for hypersensitivity reactions or autoimmune disorders, abnormalities in routine labs may suggest altered immune function and indicate a need for further evaluation. Alterations in a CBC, urinalysis, and/or serum electrolytes may be the result of an exaggerated immune response. Laboratory testing that strongly suggests an autoimmune disorder is a positive antinuclear antibody test. C-reactive protein and erythrocyte sedimentation rate tests can help determine the presence of inflammation related to autoimmune dysfunction. Tertiary prevention of hypersensitivity, collaborative interventions. Collaborative management of hypersensitivity reactions focuses on maintaining or restoring the cardiopulmonary status of the patient and shock prevention and management. Maintain an open airway, adequate ventilation, and oxygenation by administering epinephrine, albuterol, high-flow oxygen, or by intubating. Administer IV normal saline, plasma volume expanders, and vasopressors to restore blood pressure and heart rate to normal ranges. Adequately manage the patient's pain, anxiety, and discomfort using mild analgesics, bronchodilators, and corticosteroids. For less severe reactions, the priority is managing the patient's discomfort and minimizing disruptions in their quality of life. If the hypersensitivity reaction is related to an autoimmune disorder, focus on promoting patient independence, physical mobility, and self-efficacy performing activities of daily living. Growth and development considerations for hypersensitivity. Food allergies. For this section, I decided to focus on a type of hypersensitivity reaction that is common in the pediatric population. food allergies. It is estimated that 8% of children are affected by food allergies, with reactions ranging from mild to moderate symptoms, such as itching and hives, to a more severe reaction, such as anaphylaxis. Recent evidence suggests that early exposure to peanuts between the ages of 4 to 11 months reduces a high-risk infant's chance for developing a peanut allergy. For toddlers with a food allergy, close supervision is necessary to prevent allergen exposure. When a child is first diagnosed with an allergy, extensive parent or caregiver teaching should be done to help reduce the risk of allergen exposure and anaphylaxis. When a child with a food allergy goes to school, the parents, healthcare providers, and school caretakers need to collaborate on allergen avoidance and emergency treatment plans for the child. As a child grows, they can participate more in their allergen avoidance and treatment procedures. Teaching the child what foods to avoid, how to read food labels and ingredient lists, and about the signs and symptoms of a reaction is beneficial for their safety. In addition, a child with a severe food allergy can wear a medical alert bracelet. Adolescents with food allergies, especially those with severe reactions, are considered a high-risk group for fatal allergic reactions. Encourage teens with food allergies to adhere to the allergen avoidance plan at all times and always carry their medication. Promote self-efficacy by teaching them how to inject epinephrine by themselves and by practicing the technique to reduce any fear associated with the procedure. Young adults with food allergies are also considered high risk for fatal allergic reactions due to participation in behaviors that may increase the risk of allergen exposure. Discuss how impaired judgment related to alcohol consumption can be a risk factor for allergen exposure and improper treatment. For those with severe allergies, intimate behaviors such as kissing can be a possible source of allergen exposure. Encourage adolescents and young adults to reach out and join support groups for people with food allergies. By adulthood, most patients are familiar with their food allergies, allergen avoidance strategies, and emergency treatment plans. If an individual is diagnosed with a food allergy during their adult life, provide the appropriate education and teaching for avoidance and management of the allergy. Growth and development considerations for hypersensitivity. Asthma. The second exemplar I chose for hypersensitivity reactions affecting the pediatric population is asthma. Asthma is the most common chronic childhood disorder, affecting approximately 8.4% of children under the age of 17. During an asthma exacerbation, an exaggerated immune response to a trigger or stimuli causes acute bronchospasm, difficulty breathing, wheezing, chest tightness, and anxiety. When caring for a child with asthma, it is essential to ensure that their treatment is developmentally appropriate and that the child is able to use any prescribed device correctly. Children over the age of 5 are able to use a metered dose inhaler and a dry powder inhaler with proper instruction. For children under the age of 5, always use a spacer or a mask when using a metered dose inhaler. Nebulizer treatments are also appropriate for young children. Patient and family education for hypersensitivity. When conducting patient and family education for hypersensitivity reactions, consider the child's developmental level and include them in the education session when appropriate. Teach the parents and older school-age children about the signs and symptoms of hypersensitivity reaction, strategies to avoid allergens or triggers, purpose and procedures of prescribed drug therapies, and emergency management of a hypersensitivity reaction. Anyone caring for the child should be taught how to use an epinephrine autoinjector and/or an inhaler if applicable. Assist the family with creating an allergen or trigger avoidance plan, as well as an emergency action plan. Teach the child how to use their inhaler or how to self-inject epinephrine when they're capable.
Hi everyone, my name is Victoria and I will be covering Exemplar 3, which is lupus, and SLE is a multi-system chronic inflammatory autoimmune disease of unknown origin. So we will begin by talking about the risk factors for lupus. The 5 most common are gender, and it is most common in females, race, African Americans, Native Americans, Hispanics, and Asians. Age, it is primarily diagnosed in adulthood, but an estimated 15 to 20% are diagnosed in childhood. And if there's one thing that I want you guys to take away from this slide, it is that SLE in children tends to be more severe at onset and has a more aggressive clinical course than the adult onset type. There is a family history of lupus, so if a child has a mother or father who has it, their chances of developing this autoimmune disease is greater. And there's a combination of genetic and environmental factors. And I found an article during my research titled Environmental Influences on SLE Expression, and it kind of went into detail on how epigenetics does have an influence on the development of this autoimmune disease. If you guys are interested in reading that, that article is cited in the Works Cited page at the end of this PowerPoint. So now we will go into the assessment of lupus. Here I have exam findings and diagnostic tests. For the exam findings, rash, fever, joint inflammation and pain, photosensitivity, butterfly rash on the face, mouth or nose ulcers, Raynaud phenomenon, alopecia, easy bruising, muscle weakness, psychosis, dyspnea, chest pain, edema, weight loss, abdominal pain, ecchymosis, and joint deformity are the most common. Diagnostic tests. A CBC is done, blood and blood creatinine to assess kidney and liver function, ESR, which is erythrocyte sedimentation rate, anti-nuclear antibody test, chest x-ray, CT scan, MRI, 24-hour urine collection, renal biopsies, urinalysis, and skin biopsies. So how do we manage lupus? For starters, we can prevent infection by using prophylactic measures and vaccines. We can maintain fluid balance by maintaining intake and output, fluid and electrolytes, and weight. We will promote adequate nutrition by maintaining a well-balanced diet with calcium and vitamin D supplements to support healthy bones. We will promote skin integrity by educating the importance of oral care, using mild soaps and lotions, avoiding sunlight, and using SPF. We will promote rest and comfort by taking frequent rest periods, increase mobility and muscle strength by doing activities in the home. Managing med side effects. This is important because NSAIDs cause GI bleeds. Hydroxychloroquine may cause retinopathy, causing blindness, and this will lead to the child having an eye exam every 6 months. And we will avoid triggers for flare-ups, and that's avoiding sun, wearing protective clothing outside, etc. And we will provide emotional support, and we do that by giving children referrals to counselors and support groups because their bodies may change dramatically with the development of lupus by their hair falling out, weight gain, things like that. And what medications are used to treat lupus? So NSAIDs are used, and those help with inflammation and arthritic pain. Examples would be ibuprofen, naproxen, diclofenac. As for antimalarials, those protect the skin from rashes and UV light, and an example of that is hydroxychloroquine. Immunosuppressives help keep the immune system from attacking the body. Medications are methotrexate and azathioprine. For steroids, they are used for immunosuppression and inflammation, and examples of those are prednisone and methylprednisone. And so what is the goal of treatment? The goal of treatment is to relieve pain, control inflammation, preserve joint function, prevent deformities, achieve remission of disease, minimize side effects of disease and treatment, and promote natural growth and development. So here we will talk about preventative measures. We have primary, secondary, and tertiary prevention. Under primary prevention, we have education of risk factors and disease process to patient and family members. Secondary prevention includes recognition and avoidance of factors that exacerbate flares, and examples of factors would be ultraviolet rays from the sun or fluorescent lights, infections, exhaustion, physical or emotional stress, low vitamin D, and cigarette smoke, and this includes secondhand smoke as well. As for tertiary prevention, we want the child to stay in remission for as long as possible, and we do that by adhering to medical treatments, have the child go to physical and occupational therapy, and maybe rehabilitation. Some things to consider about the growth and development of children with lupus would be body image problems associated with rash, hair loss, and steroid therapy. With steroid therapy, we're going to see Cushingoid effects, weight gain, and hypertension. School attendance and performance is often affected, and the performance of children in school often declines. Vocational activities, we have to think about children and the hobbies and things that they enjoy, and if they, for example, enjoy home ec such as cooking, will their pain and potential deformity of their joints allow them to participate in those activities that they enjoy? Social relationships, this goes back to body image. How are they going to maintain their relationships when they don't feel good about themselves, or they consistently think that people are judging them and ridiculing them? It's something to think about. Sexual activity. For adolescents, this is big because we're going to have to really educate the importance of using protective barriers such as condoms. And for females, they will not be able to use estrogen forms of birth control. And psychosocial issues. Children who have SLE are at higher risk of developing depression and anxiety than a child who is completely healthy. And the emotional and social challenges, how are they going to fit into their society with a long-term disease such as SLE? And pregnancy. This was something that I didn't even think about, and it's something really important for all of us to think about when administering medications. Administering medications at a young age can significantly impact their ability to reproduce, and this is something that they need to be aware of. So some education tips for the patient and the family would be to wear wide-brimmed hats, long-sleeve shirts, and long pants when outdoors. Avoid UV light and sun exposure, and if the child is to be outside, it is necessary that they wear a sunscreen with an SPF of 30. It is essential that they do not rub the skin if the child is wet. They need to pat that skin dry to avoid irritation. Using mild shampoo and body wash. Report evidence of infection. Inspect for open areas and rashes. Apply non-fragrance lotion to dry skin. Avoid using powders, alcohols, or any other drying agents on skin. Limit use of cosmetics. For adolescents, it is important for them to understand that it is best to not drink alcohol, smoke, or do drugs, as it can exacerbate their flare-ups. And for young females, they should not be on birth control containing estrogen, as that can exacerbate flare-ups as well.
A transplant rejection is when the recipient's immune system distinguishes the donor organ as foreign and attempts to eradicate it. It is a normal immune response to foreign tissue following organ transplantation. Rejection can be hyperacute, which is within 24 hours after transplantation, acute, in the first 6 months of transplantation, or chronic, which happens over months or years, is irreversible and comes from repeated acute rejection episodes. Before I get started on risk factors, it's important to know that no two transplants are alike. Because the list of organs and tissues that can be transplanted continues to grow, every case is different and therefore can vary among individuals. Risk factors for transplant rejection are age, primary diagnosis, type of transplant, donor recipient blood type, congenital anomalies, previous rejection events, and hemodynamic compromise. With age, infants have a lower rate of rejection. Primary diagnosis. If the individual is at end-stage organ failure, they have a higher rate of rejection and mortality. The type of transplant is important to note because tissue transplants like corneal transplants are less likely to be rejected than kidney, heart, or lung. In an emergency situation where cross-matching is not performed before the transplant takes place, this increases the risk of rejection. Congenital anomalies in the donor organ are also risk factors. With heart transplants, any previous rejection events have a higher risk of rejection. Hemodynamic compromise is heart failure or perfusion failure. This is again with heart transplants, but also kidney and lung. The transplant patient will be closely monitored immediately following transplantation for rejection signs. Transplant rejection, although it is not desired, is expected at some level. Signs and symptoms to look out for are fever, tenderness or pain at the transplant site, swelling, jaundice, weight gain, a change in heart rate, and flu-like symptoms, including overall change in the demeanor, energy level, and the physical activity of the child. There are many diagnostic tests available to diagnose rejection, and they vary according to each patient. Some examples would be high blood sugar, or abnormal general blood panels like a CBC, a CMP, or a BMP, a decrease in the urine output, abnormal kidney or liver function tests, abnormal tissue biopsy of the donor organ, also imaging studies like ultrasound, CAT scans, MRIs, and many others can also diagnose rejection. An abnormal genetic profiling expression testing is also available. It's called an AlloMap. Clinical management for the transplant recipient is extensive. It takes a great team of people working together to care for this type of patient. It's a delicate balance between rejection and infection, and is case by case. But the most important intervention is aggressive infection control and immunosuppression. To reverse an acute rejection episode or to prevent an early rejection, muromonab CD3 with horse or rabbit antithymocyte globulin is used via an IV. The primary immunosuppressants used are calcineurin inhibitors like cyclosporin and tacrolimus, corticosteroids, mycophenolate mofetil, and sirolimus. Most patients are on triple therapy initially, which is reduced over time. Corticosteroid therapy is also weaned after a few years. This patient is usually hospitalized and needs constant monitoring. The primary prevention for a transplant rejection would be to perform meticulous ABO matching, human leukocyte antigen matching, and have a negative cross-match before the transplant takes place. Otherwise, individualized immunosuppression therapy post-transplant. A secondary prevention is early diagnosis with additional immunosuppressive therapy, which may include increased doses of immunosuppressants and corticosteroids, and adding polyclonal or monoclonal antibodies. Tertiary prevention would be the treatment of the rejection, long-term hospitalization, and may need retransplantation. Growth and development considerations for the transplant rejection patient. It's important to note that a transplant rejection is not a death sentence necessarily. Many pediatric patients can be suffering from a rejection for a long period of time. End-stage organ failure causes severe growth impairment. This is especially difficult time during adolescence, as the transition to adulthood with the transplant rejection isn't easy. This pediatric patient will need regular assessments to check for physical growth and emotional functioning. Long-term hospital stays are difficult for social and emotional development, so joining a support group is helpful. A lot of the anti-rejection medications may cause diabetes, especially if there's a family history. It's also difficult because the child must be cleared by a doctor before returning to daily activities, such as school, sports, or travel. For self-image considerations, counseling is recommended. We must consider the child's age and maturity level when the transplant takes place. Some nursing interventions are assessing for malnutrition, assessing the child's feelings regarding their long-term illness, their struggles in school, social situations, their short stature, or skills. We should also encourage the parent and the child to express their concerns and feelings about their situation. Referring to a social worker and counseling is also helpful. Patient and family education. It's important to educate the family that the child must take all their medications as prescribed and take them at the same time each day. If any doses are missed, they should notify the healthcare team immediately. A helpful hint is to use a pill box and make sorting pills a family activity. So that the medications don't run out, they should mark their calendars to remember when to order a refill in time. It's important to know and tell them to not eat grapefruit or drink grapefruit juice while taking cyclosporin to prevent toxicity. They should also try to use the same pharmacy to fill all the prescriptions to avoid polypharmacy. Wearing a medical bracelet that states they are a transplant recipient is helpful, and also keeping a list of other medications when they are away from their house. Protect the child from sun exposure. The child should also not clean any pet cages or litter, and they should not travel without the approval from the healthcare provider. They should also avoid crowded areas for the first 2 weeks after a transplant. They should eat a balanced diet as ordered by a dietitian.
Hi, my name is Lexi, and I will be going over the slides in regard to immune response. According to Medline Plus, the immune response is how your body recognizes and defends itself against bacteria, viruses, and substances that appear foreign and harmful. Before we get into the specifics of risk factors, clinical management, preventative measures, growth and development, and patient education of the immune response, let's do a quick overview of how the immune response works. There are 3 mechanisms for the normal immune response, which are defense, homeostasis, and surveillance. Defense, which is the body's way of protecting it against invasions by microorganisms and prevents the development of infection by responding immediately by attacking foreign antigens and pathogens. Homeostasis is the body's way of digesting and removing damaged cellular substances, and surveillance is just looking out for mutations that are common in the body and are normally recognized and destroyed before they can cause any issues for the patient. Risk factors for the immune response. The risk factors that weaken or alter the immune system are interrelated in the categories of modifiable, non-modifiable, genetic, environmental, and social influences. In other words, there are certain topics that may appear in more than one category. The modifiable factors are influences that can be changed if need be.
such as learning how to properly wash your hands to reduce bacterial exposure, changes in sleep cycles so that the patient is getting more sleep to make the immune system stronger and have less sick days. Nutrition also plays a key role in having a stronger immune system. For example, if the patient is not eating healthy, the body does not have enough fuel to properly take care of itself. And last but not least, the last modifiable factor is cortisol levels. This is when the body is in a continuous stressful environment, whether that being home life or school life. The body is preoccupied by dealing with stress that the immune system may suffer, and the patient gets sick more often. The non-modifiable factors include genetics that focus on genetic abnormalities in immunoglobulins, T cells, B cells, and other immune system cells that are responsible for the immune response. The next factor are various disease processes that can interfere with immune systems, such as HIV and cancer, just to name a few. Medications, such as various immunosuppressants that are used during cancer treatment or autoimmune diseases. The medications include corticosteroids, calcineurin inhibitors, cytotoxic drugs, and monoclonal and polyclonal antibodies. And the last one that cannot be modified is the patient's age. As the individual gets older, the immune response ability decreases. However, for this class, in newborns, the immune system is immature with inadequate lymphocyte function. At the same time, maternal antibodies are being destroyed, leading to a risk for infection. Risk factors for the immune response continued. There are several immune response factors. However, there are many social and environmental factors that contribute to an altered immune response. Anything that can cause an immune response is a risk factor for the patient. The obvious mediators are items such as pet dander, tree and plant pollen, pollutants from factories, fireplaces, agricultural areas, and highways where buses, cars, and other vehicles travel. Heating and cooling systems, as well as carpeting, foster many dust particles, mold particles, or any other particles that can cause an immune reaction. Bacteria that the patient is exposed to is also another common risk factor, as well as economic and social status. Every environmental and social risk factor that I have mentioned up until this point makes logical and scientific sense. However, it has been shown that economic and social status has been linked as a risk factor for an altered immune response. Think about it this way. Low-income families may not have financial assistance to afford a brand new heating or cooling system or up-to-code living arrangements, and can be exposed to various particles that can trigger the immune response in the body. In comparison to those who have financial opportunities, are able to spend more money on hypoallergenic carpeting or pets and air cleaning machines. Assessment for the immune response. So before we even try to examine the child, we want a family history of diseases and all of that good stuff. So there are several questions that you can ask to get a family history, especially for immune responses. I have narrowed it down to 3 general questions just to get us started in this PowerPoint presentation. The first question is, does a family member have a history of any allergies or allergic reactions? The second question is the mother HIV positive, or has any other family member been positive for HIV? And the third question is, has the child been treated or had a preventative treatment for HIV after the mother has been tested positive? Now we will be moving to the examination findings. So the first category is growth and development. You're going to be looking at things such as, is the child's growth regular? Are they meeting developmental milestones? How is the child's nutritional intake? And how is the child's appetite? And you can usually get questions 3 and 4 about nutrition from the parent or guardian, asking for a 24-hour
diet recall, just kind of seeing what they have consumed in the last 24 hours. Has it been a lot? Has it been a little? Those questions will be geared towards more of asking the parent and guardian, and if the child's old enough, you can kind of ask them, about their appetite or what they like to eat. Next, moving on to skin and mucous membranes. So we're going to look at this child's skin, make sure it's intact. Are there any lesions or skin abnormalities on the mucous membranes? And if so, we can ask the parent and guardian, do the lesions heal quickly without additional infection? Then we'll be moving on to evidence of disease. So does your child have a history of reoccurring or unusual infections? Then going to the head-to-toe assessment, bringing it back to level 1 nursing, your objective data, your subjective data, looking at your patient from a holistic approach, listening to lung sounds, listening to heart sounds, getting vital signs, pain levels, everything that regards to head-to-toe assessments. Then diagnostic tests, so your skin tests, which are going to have 3 different categories: your intradermal skin testing, your scratch or prick test, and your patch test. So all of the skin tests, basically, they make a scratch on your skin and kind of insert a small amount of the antigen and introduce it to your skin, and then they check back and see if you developed an immune response or if you're not allergic to it. And then they can also take a sputum, nasal, and bronchial secretion diagnostic test. The next are the laundry list of labs that can be ordered to evaluate the immune response of a patient. So CBC with differential, absolute lymphocyte and eosinophil count, T cell and B cell quantification. They can also check complement, and complement is a system that clears microbes and damaged cellular substances by activating the body's inflammatory system and attacking the plasma membrane of the foreign body. So then we go to your immunoglobulins, and we have 5 different immunoglobulins in our bodies. That's IgG, IgE, IgM, IgA, and IgD. So IgG is active against bacteria, bacterial toxins, and viruses. It also activates complement, like we talked about before. This is the only immunoglobulin that crosses the placenta. So when the baby's born, IgG is the only immunoglobulin that comes with the baby. The rest of them are left behind. IgE releases chemical mediators responsible for the immediate hypersensitivity reaction. So that's your scratching, your redness, swelling, stuff like that. IgM, it mediates cytotoxic responses and activates that complement, just like we were talking about. This type of immunoglobulin is the first antibody that is produced during the primary immune response. IgA prevents antigens from binding to cells within the respiratory and the GI tract. And IgD, its function is not completely understood yet. And the last test that can be looked at is, of course, the HIV testing. Clinical management for the immune response. Collaborative treatment strategies vary depending on the severity of the illness, whether you are supporting the weakened immune response or treating the consequences from the immune response. No treatment is the same for every patient. Here is a list of possible treatments for suppressed immune response and exaggerated immune response and their clinical outcomes. For the suppressed immune response, we're going to be looking at infection, GI dysfunction, skin disorders, and nutrition. Specifically, when looking at the clinical management side of things, for infection, we're going to be looking at hand hygiene, immunizations, standard precautions for reducing infection rates. That's just, washing your hands, staying away from people who are sick, stuff like that. For GI dysfunction, the pharmacologic treatment of diarrhea, candidiasis, and fluid electrolyte loss. For skin disorders, clinical management is the pharmacologic treatment for skin rashes. And nutrition, the clinical management side, is multiple vitamin and mineral supplements, dietary supplements such as Ensure or an equivalent to Ensure, and the evaluation of weight and body mass index, or BMI. The clinical outcomes for a suppressed immune response are the resolution of infection, making sure that the GI tract has a normal transit time. Any skin rashes that have been found are resolved, and restoring hydration levels, nutritional status, and normal weight and BMI levels. For the exaggerated immune response, we are going to be looking at anaphylaxis, immunosuppression, pain management, stuff like that. The clinical management side for anaphylaxis is to support the airway, breathing, and circulation. So remember your ABCs. You're going to administer subcutaneous epinephrine if this is a type 1 reaction. The use of bronchodilators, intubation, and ventilator support if appropriate in that situation. You're also going to be looking at the use of circulatory volume expanders, vasopressors to maintain adequate blood pressure and circulating volume, and pharmacologic aspect of anaphylaxis is the epinephrine and the bronchodilators. When looking at immunosuppression, the pharmacologic treatments are corticosteroids or chemotherapeutic agents, NSAIDs, or immunomodulators. For pain management, we're looking to, decrease that pain, make sure you're taking or asking the patient, if appropriate, their pain levels, what they usually take for pain, stuff like that. So the pharmacologic treatment are NSAIDs and corticosteroids. We're going to look at hypo and hyperthermia treatments if appropriate. Remember, we're wanting to go from least invasive to most invasive. Then we're going to look at to maintain maintenance of mobility and physical activity for pain management. The clinical outcomes for an exaggerated immune response are, of course, adequate ventilation, restoration of blood pressure and pulse. We're going to make sure that urine output is normal for that patient. We're going to make sure that they're showing adequate circulatory volume, make sure that hypersensitivity response is modulated or decreased. We're going to make sure that that patient's pain has been managed, that it's controlled, or has even stopped. We're going to make sure that the patient can be moved and can have joint and muscle mobility, that they can care for themselves if this is a patient who has that ability, and restoration of maintenance of adequate levels of physical activity. So getting those body parts moving without pain or stiffness, anything like that. Primary, secondary, and tertiary prevention for the immune response. Primary prevention falls under two categories, which are vaccinations and reduction of modifiable risk factors that were noted in the risk factor slides. So for vaccinations, the CDC's Committee on Immunization Practices has a vaccination schedule for children, adolescents, and adults. There's also a catch-up schedule for those who have missed vaccines in the past. You can find this information on the CDC website, or you can Google CDC vaccination schedules, and it should pull it right up. For the second for reducing modifiable risk factors. So examples are hand hygiene, immunization, stress levels, sleep cycles, and nutrition. This also means avoiding risky behaviors, so minimizing exposure to environmental triggers such as pollen from flowers and trees, pet dander, and pollutants, to name a few. Eating healthy and maintaining an exercise regimen has also been listed as a primary prevention for the immune response. According to Giddens 2017, research has demonstrated that achieving the daily recommended doses of vitamins and minerals contributes to a properly functioning immune system, and this can be found on page 224 of your Giddens book. Role of vitamin A and D also have been shown to protect and support immune function and responses as well. Secondary prevention mostly lies under screening, so for the presence or emergence of immune disorders, screenings for that, specific screenings for immune function that were listed in the slides before, examples of screenings for specific immune function is your absolute lymphocyte and eosinophil count, T cell and B cell quantification, immunoglobulin testing, and various skin tests. Screenings for HIV, especially for high-risk groups, is also falls under secondary prevention, as well as genetic testing. For tertiary prevention is a way to help soften the blow if you have an immune response that cannot be cured, and it also helps the patient cope with this type of disease process. For a weakened immune system, tertiary prevention can be support groups for those having to cope with their new normal. This aims to reduce the severity of the disease as well as symptoms or issues it may cause. So tertiary prevention focuses on, okay, I have this issue, let's see how I can make it better or reduce my symptoms, but it's not really along the lines of preventing it or curing it. And lastly, rehabilitation efforts is also listed under tertiary prevention. Growth and development considerations for the immune response. As we know, the immune system adapts within the individual as they come in contact with various particles, bacteria, and vaccinations. So for this part of the PowerPoint presentation, I chose 2 questions to answer for a discussion. How does immunity grow and develop within the human body, and how does preterm birth affect the immune system and the way it grows and develops within the child? According to Lumen.com, neonates are physiologically immunodeficient, meaning both their innate and adaptive immunological responses are greatly suppressed. Once born, a child's immune system responds favorably to protein antigens and less to glycoproteins and polysaccharides. In fact, many of the infections acquired by neonates are caused by low virulence organisms like Staphylococcus and Pseudomonas. In a term infant, the number of lymphocytes are higher than an adult. However, their cellular and humoral immunity is decreased compared to adults. This means that they have a decreased ability to activate T cells and produce less cytokines. Maternal influences on the infant's immune response comes from IgG. Remember that immunoglobulin that can pass through the placenta? However, IgA is passed through breast milk if the mother chooses to breastfeed. This is also called passive immunity. Immunity during adolescence occurs when the child is changing physically, physiologically, and immunologically, which is mediated all by hormones. According to now looking at the preterm side of immune response for infants, according to Ball, Bindler, Cowan, and Shaw in 2017, newborns are most prone to development of infection, particularly when born prematurely because they have lower levels of their own immune protections. Human milk contains immunologic components that can influence the immune response, so that IgA, passive immunity, to the infant, and it will help the infant be protected against infection. You can find this information on page 566. In an article that I found by Melville and Moss in 2013 from the Frontiers in Neuroscience, they researched the immune consequences from preterm birth. The article dives into specifics of immune function in preterm infants in comparison to their term counterparts. In the article, it states that many preterm infants have significantly lower levels of immune function cells, such as naive T cells, monocytes, neutrophils. They also have the impaired ability to kill pathogens, and they also produce lower amounts of cytokines and don't activate as many T cells as a term infant would. Reduction in immune cells reduces the infant's ability to fight bacteria and properly detect viruses like term infants do, and it also goes into detail how this can impact the preterm infant's immune response in the future, because the immune response is having to play a catch-up sort of game, if you will. Nursing interventions that follow growth and development for the immune response, these were found within the article, and they kind of go with medical interventions as well. So antenatal corticosteroid treatment. So this prevents newborn respiratory disease. It's usually a routine treatment, but it also acts as an immune suppressant. And it's also associated with febrile responses, reduction in lymphocyte proliferation, and increased risk of infection. The second one is invasive medical procedures result in an increased risk of late onset sepsis, respiratory support that can cause chronic inflammatory lung disease associated with increased risk of long-term morbidity. It also goes into detail about C-section births that affect the infant colonization and potentially contributes to a lifelong immune function problem and well-being. Also goes into several factors associated with preterm birth that alter the immune function. So after all of the following medical interventions have been described within the article, the nursing interventions that would follow would be first and foremost patient education on the following treatments, as well as the risks associated with each medical treatment. Patient education is a nurse's strongest skill, and the patient education on why the treatment is being ordered and how it will be administered puts parent and guardians' minds at ease that we know what we're doing and they know exactly what will be happening and what side effects and precautions that they may need to take. Patient and family education on the immune response. As said previously, patient education is one of the nurse's strongest skill sets. So with that being said, we want to teach patient and family members the following. 1, signs and symptoms of infection, what to look out for, redness, fever, stuff like that. 2, the importance of hand hygiene and how that can reduce bacterial exposure. Number 3, we want to teach the importance of staying up to date on all vaccinations, and if they aren't up to date on all vaccinations, provide a catch-up schedule per CDC recommendations. Number 4, signs and symptoms of influenza and the importance of annual influenza vaccination, not only for the pediatric patient, but the family members surrounding the patient. Number 5, the importance in avoiding environmental triggers such as pet dander, dust accumulation in the household, or plant and tree pollen. Number 6, the avoidance of modifiable risk factors. So going back to the sleep cycles, nutrition, vaccinations, stress levels, examples like that. Number 7, the importance of breastfeeding. If the mother is willing to breastfeed, and provide education on how that can contribute to the infant's ability to strengthen the immune system. So going back to passive immunity and the immunoglobulin A, and how that education can help the mother decide whether she wants to breastfeed or not. Number 8, the importance of proper screenings to ensure that the patient is getting the help they need. So going back to those screenings of skin tests and various immune cell function tests to make sure that the patient is being helped to the fullest. Number 9, signs and symptoms of anaphylaxis or life-threatening allergic responses and where to get emergency help. Number 10, stressing the importance of adequate diet and exercise on the immune system, just teaching patients and their family members about how many servings of fruit and vegetables they should be getting a day and what a healthy diet looks like, sharing, my plate options, showing them what they can do to get an adequate diet and exercise regimen going. And lastly, the proper use of an EpiPen. So if patients have an allergic response, say to nuts or shellfish or anything like that, they know how to use their EpiPen, they know how to call for 911, they know how to do these things. Not only is it important for family members of pediatric patients, but when children are school age and they're out in the school setting and their parents are not always there to remind them of, this is how we use our EpiPen and this is how we do things. So the importance of teaching the proper use of an EpiPen and how to call 911 is extremely important.
Okay, so now that we have shared 5 different exemplars with you guys related to immunity, we have 3 different discussion questions for you. So let's talk. What do you think? Discussion question number 1. What are immune consequences of a preterm birth? What are some ways to support the premature infant's immune system?
Discussion question number 2. What are some of the possible reasons for the increase in frequency of autoimmune diseases? Are there possible environmental, geographical, lifestyle, and/or genetic factors that contribute to the likelihood of developing an autoimmune disease?
Our third and last discussion question for you guys is, in relation to immunity, why should vaccines be administered and how are they beneficial? If a pediatric patient is immunocompromised, what are important considerations to make? Thank you guys so much for listening. This is all we have for you guys. I hope that you were able to learn a lot from the different exemplars and information that we provided you. We also hope to see a lot of different responses for our discussion questions. And as well, if you guys have any questions for us, please feel free to post those and hopefully we are able to get back to you. Thank you.